Okay, so let's move forward. We are talking about the acute spinal cord injury. That is a traumatic event that results in disturbance of normal sensory, motor, and autonomic function, and ultimately affects a patient's physical, psychological, and social well-being. As you know, we have the cervical, thoracic, the lumbar, and the sacral and the coccygeal region of the spine, and also we have different nerve roots that are moving outside of the intravertebral foramen. The prevalence of spinal cord injury is between 14 and 40 per million cases, but usually this is a severe trauma that happens, that leads to the decrease of the quality of life. Usually it's the paraplegia when we have the paralysis of the lower extremities, or it's the quadriplegia or tetraparesis when they have the paralysis of all of their extremities. The patient cannot move with his extremities. He is the unfunctional. Yeah, he can speak. His head and his brain is still working. Yeah, but it's very extremely poor prognosis for this patient and for his family and the community of this country, because it's the huge financial, he requires a huge financial burden for this patient. So there are a lot of mechanisms of injury. The common mechanism of injury include the hyperflexion. Yeah, when you have the hyperflexion, the most commonly is the driving accident. We have the hyperextension, is the frequently fall or striking on an object on the way down. And also you have the axial load. When you have the vertical compression, usually it's the fall from height on the legs. When we have the vertebral body compression. So before we start talking about the spinal trauma, yes, I would like to reinvent some basic anatomy. So the spinal cord starts from when the brainstem terminates. Here we have the nerve roots that are coming from every intravertebral foramina. Here we have the spinal nerves. The vertebral column consists of the vertebrae and the intravertebral disc that are very important in case of degenerative spinal disease. Yeah, but in case of the spinal trauma, usually we have some problem with the vertebrae itself. The spinal cord consists of three main types of fibers. First of all, it's the motor fibers that are localized in the frontal part of the spinal cord. It's the sensory fibers that are localized in the posterior part, and it's the autonomic nervous system nerve roots that are localized in the lateral corticospinal, in the lateral tract. Okay. Here we can see different dermatomes. What is the dermatome? It's the part of the skin that is precisely innervated by some nerve root. So we can check some sensation or vibration in this area, and we can observe some disorders in these special areas. For example, the C6 nerve root is innervated first and second finger, and we can check the sensation of these fingers. And also C6 nerve root is responsible for the biceps reflex. Yeah, we have the bicep wrist extensors reflex. And when we are checking the biceps reflex, we are checking the exact work of the C6 nerve root. So if we have the spinal cord injury, sometimes we can face with some disorders that are called the spinal shock and the neurogenic shock. The spinal shock is the so this is something that is very similar to the brain concussion. Yeah, it's the brain concussion, but of the spinal cord. We have the absence of some voluntary and so we have depressed motor and sensory pathways that will lead us to some depressed neurological activity under the level of injury, but this state is transient. Yeah, the motor activity will come back. If you are talking about the neurogenic shock, yeah, this is the hemodynamic phenomenon. Yeah, it's the loss of vasomotor tone and loss of sympathetic nervous system tone that will lead us to impaired cellular metabolism. Yeah, because the patient will have some hypertension, bradycardia, poikilothermia. So this is the injury of the autonomic nervous system, and we have the loss of the sympathetic activity of this autonomic nervous system, and the patient will have increase of the parasympathetic activity. As well as, you know, the parasympathetic activity is provided through the central nervous system, yeah, especially by the nervus vagus. So the patient will have hypertension, the hypertension, arterial hypertension, yeah, due to the massive vasodilation. He will have the bradycardia due to unsupposed parasympathetic stimulation of the nervus vagus. And this will lead his patient to the to the shock situation. Yeah, he will have some problems with airway. Yeah, he will have the bradycardia and blood supply insufficiency. So next, I would like to talk about the autonomic dysreflexia. So this is the special condition that can happen in patients with the spinal trauma, usually about T6. So, it will lead the patient to the uncoordinated autonomic response, noxious stimulus that occurs below the level of the spinal cord lesion. So in these patients, we can observe some serious complication. Yeah, for example, seizures, cardiac arrest, some cerebrovascular hemorrhage, bladder or bowel distension are the most common triggers of this situation. And we should sit the patient upright and eliminate triggers that are triggering this situation. In case of the spinal cord injury, we use some scales to measure the patient's state and also to provide some prognosis to the patient's family. The most widely used are the Frankel classification of the spinal cord injury. It's A, B, C, D, E, and the Asia impairment scale. So as you can see, they are absolutely the same. The E is the best prognosis for the spinal patients. The motor and sensory function are normal, and A is the worst. No motor, no sensory, no sacral sparring. This means that the patient has poor prognosis for his next life. This is the cross section of the spinal cord. As you can see, there are a lot of tracts that the spinal cord is providing. The posterior tracts that are responsible for some deep sensation. Also, we have some anterior tracts like the spinothalamic tract. Here we have some pyramidal tracts that provide the motor corticospinal tract, and the anterior corticospinal tract that provide the motor function. And also we have some afferent pathways that provide the upcoming of the sensory information in the central nervous system. When we are talking about some spinal cord injury, we have some spinal syndromes. First of all, we have the central cord syndrome. Usually it's the fall with hyperextension. It's much more commonly observed in the elderly patient. In the elderly patients, the patient usually this is the result of hypoextension, producing force both anteriorly anteriorly to the spinal cord with the bulging of the ligamentum flavum. It rarely involves fracture. The fracture are not very common in this situation. Generally has a good prognosis for the recovery, but it involves spinothalamic and corticospinal tracts for upper extremities. And this patient presents with the weak upper extremities, variable bowel and bladder dysfunction, disproportionately functional lower extremities. So next we have the anterior cord syndrome. This is the primary hyperflexion mechanism, usually occurs as the result of strong flexion of the anterior spinal cord, producing some herniation of disc or bone fragments to the anterior part of the spinal cord, or it can be the occlusion or interruption of the spinal artery, which fits the anterior two-thirds of the spinal cord substance. So the motor function, pain, temperature, and gross touch sensation is lost. The proprioception, vibration, and stereognosis are intact. And we have the loss of corticospinal and spinothalamical tracts that lead us to the motor paralysis. Next, we have the Brown-Séquard syndrome. So Brown-Séquard syndrome is the hemisection of the spinal cord, usually from the penetrated injury. It's like knife trauma or maybe some other trauma that will produce the insufficiency of half of the spinal cord, insufficiency of function. So it's the ipsilateral loss of motor proprioception, vibration, and stereognosis, and contralateral loss of pain, temperature, and gross touch sensation. So we have the loss of motor function on the site of injury, and we have the loss of sensation on the opposite side. But it is important that the deep sensation will be also lost on the site of injury. So next we have the diagnostic procedures for the spinal injury. So usually we perform some X-rays in the emergency department to see some fractures. The next step is the providing of the CT scan. As you can see on the CT scan, we have the anterior dislocation of the spine. And then we can perform the MRI, where we can observe some soft tissue. We can see some spinal cord tears or some spinal cord impairment. We can see some local demyelinization. And this can help us to better understand the clinical situation. So what is the proper management of the spinal trauma? So we have, in first minutes, we have the immediate management. Usually it's the mobilization, if the patient is has some life-threatening condition, we should provide some ABC reanimation via the airway and the blood circulation. Next, we should limit the motion. Yeah, we should provide the mobilization. A lot of traumas have the secondary, they are secondary due to improper transportation of the patient. There are a lot of patients with, for example, neck trauma or with neck spinal cord injury that have the neurological deficit not from the primary trauma, but after the non-professional transportation. So if you observe the patient with this cervical trauma, you should start from the immobilization. After the patient comes to the hospital, we have some acute management. Yeah, we should consider the provide some diagnostic tests, neurological examination, neuroimaging, CT or the MRI, and if the patient is in risk of the brain compression, yeah, we should provide the early decompression in the first 24 hours. If the patient has spinal cord injury, we provide some neurological examination, and he is some spinal cord compression, we should consider the early surgical decompression. If the spinal cord is intact, he has no neurological deficit, but only some orthopedic problem, yeah, like the brain, the bone fracture and so on. Yeah, we shouldn't, in most cases, we shouldn't perform the acute surgery. So as you can see here, this is the management of the patient with the spinal cord injury. It's the emergency care, medication, immobilization, surgical treatment, and this is one of the most important and one of the most longest period of the treatment. It's the rehabilitation. Usually it's some physical therapy. So thank you for your attention. I hope that this lecture was interesting for you. See you in the next lecture.